Hello and welcome. I'm Brett McReynolds, Vice President of Public Policy of the Autoimmune Association and Executive Director of Let My Doctors Decide. I'm honored to be joined by rheumatologist Dr. Madeline Feldman, an adult rheumatologist, and Dr. Harry Gawanter, a pediatric rheumatologist, as well as the Executive Director of the National Organization of Rheumatology Management, Andrea Zlakis. Beyond their traditional roles, they are advocates for patients and providers, particularly when it comes to addressing access barriers that prevent patients from getting doctor-recommended medicines and treatments. During this discussion, we'll cover access barriers and other issues that are taking center stage as part of the national dialogue on healthcare issues. So let's jump into it. One issue we are hearing about is a rather disturbing trend in rheumatology, where it is getting increasingly more difficult for doctors to actually practice according to their training, especially in today's challenging environment. Do you find this to be the case? And if so, why? We'll start with you, Dr. Gawanter.
I think absolutely that's true, and there's a number of reasons. The first is that there are just not enough of us. There's only about 400 pediatric rheumatologists, for example, and we're projecting at least an 8,000 person shortage for adult rheumatology looking into by the end of this decade. So a lack of folks is one big thing. And I think the other is that it's just more difficult to get into a fellowship now, whether it's pediatric or adult, because we don't have enough slots for fellows. And so we need a lot more GME funding, realizing, of course, it's going to take 8 to 10 years from the time you start in medical school until the time you're able to practice.
Dr. Feldman, do you also find it difficult to practice in today's challenging environment? If so, why?
Absolutely. And I think it kind of revolves around two things. In order to practice, you have to have the time to practice. And there are a couple of aspects that have limited that time. Number one, we have more than half of the physicians now in practice are employed. Therefore, there are time constraints. They're told it's all based on RVUs and how many patients you can see. That in and of itself constrains your ability to practice rheumatology. Then number two, for every 2 hours of time spent in the office, only 1 hour is devoted to patients. And that 1 hour, half of the time is spent on your computer. So we've turned into billers and coders. So that right away has sort of diminished the ability to practice rheumatology. And then the second big reason is, even if you have the time, you are told what tests you can order, where you have to send them. So you spend a lot of time doing that. And then, of course, as we all know, our ability to do shared decision-making in terms of medication has been taken away from us and given to the pharmacy benefit managers. So you put all that together, and yes, it is difficult to practice rheumatology these days.
Thank you, Dr. Feldman. Andrea, as the patient advocate in the front office, are you witnessing similar trends? If so, what advice do you have for staff and for patients?
Yes, I'm seeing similar trends in our practice as well. Utilization management techniques, as we've discussed here today, are increasing every year. However, I truly believe once that physician and the patient has made that treatment decision, we should do everything in our power to make that decision come to fruition. And so I would encourage all the practice managers there to not take that path of least resistance, to kind of stand up and fight for that treatment decisions. If we do that, right, I really believe that when I do appeals, about 90% of them are overturned, and it is really worth doing that. I think it's a tactic that the insurance companies are counting on that we're just going to give up.
Absolutely. Dr. Feldman, what changes would you recommend to improve the environment in order to maintain much needed rheumatology specialists as well as attract new providers?
Well, the workforce issue is around and is going to be around for a while. Things are looking up in terms of rheumatology. The matching has increased by about 7% per year. There have been new programs added. The problem is that there's a lot more probably rheumatologists retiring than there are coming into the specialty, number one. And then there are a lot more people entering into the disease state. There is increased recognition. but there's a lot more autoimmune disease out there that we're finding. So when you put those two together, we're having a problem. One thing is rheumatology has probably is looked upon as a specialty where there is an increased sort of life-work balance, which is good. But on the other hand, that means that in order to achieve that life-work balance, women and men may be taking more time off to spend with their family, which is good. But unfortunately, that sort of tips the scales towards not having enough rheumatologists to take care of all the patients out there. So you're sort of looking at a double-edged sword. That which is attracting people to rheumatology may also be, lessening the number of hours that are put in every day. We are making advances, but has been mentioned, we really do need to increase the training slots. And perhaps if we taught medical students a little bit more about the simple things in rheumatology and even the residents, we might be able to make up for a little bit of that loss of manpower and woman power.
Absolutely. Dr. Gwanter, what changes would you recommend?
I think, again, one of the big problems, is the fact that, physicians are being turned into line workers when you're employed, and also by the payment system. We are basically charged to make money off of how many people we see. And as cognitive specialists, really, we should be billing for time, just as lawyers or other specialists do. Because all we can offer is what's in our head. We don't have a lot of procedures that we can bill for. So that's one issue. I think the other thing, to just expand on what Dr. Feldman said, is the whole moral injury issue that we're facing, being line workers, where you know what the right thing is to do, but you are unable to do it because of various rules. And I think that the key is we keep batting around the term personalized medicine. I think we actually need to be able to practice personalized medicine by having a patient, physician, and pharmacist and other team members make a decision and be able to implement that decision.
That being said, I would like to add to the fact that I think once, whether it's a resident or fellows, once they start in their training and actually see what rheumatology is, I mean, I have to admit, it is an amazing specialty. It is, you make changes in people's quality of life, even if we oftentimes can't cure them. And I think that is one of the really big attractions. And as long as we can keep doing that, I think we'll keep attracting people. It is those barriers that are put around us that keep us from doing the thing that brought us to rheumatology in the first place.
And I think one of the issues is that, rheumatology is mainly an outpatient specialty. And when you're going through your training, you don't see the outpatients very much in subspecialties like ours. And so residents, and again, especially in pediatrics, are not exposed often to the rheumatology field for them to even be able to consider it as a specialty.
Absolutely. And, on top of these barriers that you're already mentioning, from the patient perspective, we are all too familiar with these frustrations, particularly in accessing specialists like yourselves, complicated by further restrictions that hinder the ability to access prescribed medicines, further delaying health and wellness, and putting at risk this critical doctor-patient relationship. So how serious is this problem? Andrea, we'll start with you.
Sure. I think it's very serious. These delays really delay patient treatment and they're suffering, right? So I have seen up to like 2 months to get the appeal process done. But also our patients are receiving letters from the payers that say, hey, there is a more or as effective and less costly treatment. And so that's why they're denying it. And it also kind of erodes the trust between the physician and the patient. And they're coming back to us and saying, why are you giving us this treatment when there is a better treatment out there?
Absolutely. And Dr. Feldman, we know this is a serious problem. What are you seeing that's causing these harmful delays?
Well, first off, we have to address the delay in getting to see the rheumatologist. You look at access as two things in my mind, availability and affordability. So let's first talk about availability. One of the things that has sort of come out of COVID is telehealth. And we know even when we have, whether it's nurse practitioners, other rheumatologists who want to go into practice, oftentimes we say, well, we need more people so they can go into the rural areas. Well, even when we have more people, they tend to stay in the urban areas. So telehealth has enabled us to be able to actually get out to those folks that would have to travel hours. And I'm sure Dr. Gawanta can talk about the difficulties with pediatric rheumatology. So first off, you've got to be available. And then secondly, what Andrea was talking in terms about delays in treatment, the doctor-patient relationship is based on trust. Trust that the doctor has your best interest in heart. And when we have competing interests where it's actually the interest of the insurance company that seems to take over and come in between the doctor-patient relationship, absolutely, it breaks down that trust. Even, I can explain to patients, I only have these choices, but it still chips away at that trust, which I think is the basis of the doctor-patient relationship. So whether it's interference with what medications we can pick, whether it's delayed in terms of prior authorizations, whether it's the non-medical switching in the middle of the year, the only thing the patient feels is, I don't feel good anymore. Doctor, I came to see you because I thought I was going to feel better. And that's very, very harmful, very harmful.
Absolutely. Dr. Gawanta, what are you seeing and that is causing these harmful delays?
I think all those things that have been mentioned. I mean, we have data that shows that if you, as Andrea said, that 90% of denials are approved ultimately. Now, if you look at the step protocols, 85% of them we're fine with, But now we're talking about the 15 to 20% that need a different decision, and it's getting delayed. And of those, 95% are going to be approved if you push hard enough, which takes more time away from seeing patients, oh, by the way, and increases administrative costs, which currently, if you look at the United States, it's, between a quarter and a third of all healthcare costs are based on administrative delays like this. And so ultimately, we're talking less than 5%, probably less than 2% of treatment decisions ultimately are finally denied. And while in the meantime, you're having damage because of uncontrolled disease. Once you lose cartilage cells, they're gone. They ain't coming back. Similarly, if we have someone who has inflammatory bowel disease, they may end up with surgery as a result of these delays. And so those kinds of decisions, again, affect, the moral injury for us because we're unable to make that happen in a timely fashion. If you think about it, the only thing that has remained the same over the last, 30, 40 years in healthcare is the doctor-patient relationship. Everything else has changed. But that is what this is all about. And, sitting with the patient, having a relationship with the patient is the essence of rheumatology and medicine. And that is being taken away. And I think those are some of the real difficulties we're facing from both the patient side as well as the physician and provider side.
You ask about what reforms can, be implemented in order to somehow fix this. I mean, we're talking about fixing an entire healthcare system. As more and more doctors become employed, that's not going to fix the amount of time doctors have with patients because it all boils down to the profits for the employer, number one. Number two, the insurance companies and PBMs that are controlling, how long it's going to take, what drug our patient can get, what order they can take it in, where they can pick it up, how much they're going to pay for it. to put reforms in that, we're having to go into legislation, and we're working hard at state legislation and federal legislation that is addressing, whether it's non-medical switching, step therapy, prior authorization, but ultimately that's just sort of nibbling around the edges. Then you talk about, well, let's go to the Federal Trade Commission and see if maybe some of these mergers with the companies that are controlling our patients' health, has that created anti-competitive behavior that's causing prices to rise. So that's another agency that we can go towards. But ultimately, rheumatologists aren't going to be able to put in one reform that's going to fix all of this. It's going to require fixes from all different points of view. And some have said it would take a complete disruption of how the healthcare system is being paid for before we can actually make any meaningful change.
I think one of the differences is, everybody needs to make a profit because we all have to buy groceries and, but there's a difference between profits and profiteering. And what we're seeing now with the large corporations and the vertical integration is a lot of profiteering. And so that money is being extracted from the system and not reinvested. And if we could reinvest, those sums, for example, the almost $500 billion that have come out for PBMs, if that could get put back into the system, everybody would be a whole lot better. Sorry to interrupt, Andrew.
That's okay. It's okay. I think sometimes too, we put all these efforts into state laws and they get passed, but then you have the ERISA plans that don't have to pay attention to them. And that's also very frustrating. It's something that I think needs to change.
Absolutely.
So we would encourage everybody to have their federal legislators support the Safe Step Act. It's HR 2163 or the Senate Bill Senate 464, introduced by Representative Ruiz and Senator Murkowski, respectively.
So one of the other reforms, or perhaps ways to fix it, not automatically, would be to increase transparency in the entire process. And there are bills out there that would increase transparency from manufacturers as well as pharmacy benefit managers, because it's really hard to figure out how to fix something if you have absolutely no idea what's going on. So I think we can start chipping away at some of the opaqueness that might make a difference.
And if I can jump in also, I think one of the major issues that is confusing people about this is we all talk about prices, and we all know what the list prices are, but nobody knows what the net price or the cost is of either the treatments or the services. And we need that kind of transparency so that we can look at the true costs involved in healthcare, and not just rheumatology. But once we know the costs, then we can see where we can apply some solutions.
Well, thank you, everyone. Thank you to the panel, and thank you to the participants for joining our discussion today, The State of Rheumatology, Barriers to Practice and Challenges for Patient Care. Have a good day.